I want to ask two questions. One is that the inclusion of patients with transient ischemic attacks in clinical trials for indication of being randomized as the first, should it be included in the study? Because most of us would agree that there is a definite way of diagnosing a transient ischemic attack. And the second is that the other way is that if you have a patient who is a high risk...
I disagree with that. I absolutely disagree with that. I've seen about 400 patients now, and the neurologists send in these patients, their diagnosis is transient ischemic attack. My diagnosis, almost invariably, is migraine, is complex migraine. The normal MRI, who's right? How do you prove it?
Right. So the recent recommendation by the American Society of Neurology is basically around classifying the transient ischemic attack as an event that has a parenchymal somatic correlation and lasts greater than 10 minutes. And if it lasts less than 10 minutes, it has to have an MRI finding of a diffusion-weighted defect. So they're trying to get their arms around it more clearly, but what you're suggesting is also a problem that we have, that this sort of acephalic headache or migraine, or this focal neurologic deficit migraine is really something that does confuse the issue. But it's interesting, at least sounds like your practice is similar to mine, that there is a lot of neurologists who are very, very comfortable with referring these patients for PFO closure.
Just to clarify, I shouldn't be clarifying, but there is a TIA. For example, if you just have a funny symptom in your right hand, I agree that's not probably a migraine or a TIA, but if you have a definite faciobrachial weakness, which can corroborate with a single lesion in the brain, that, in fact, in the Closure 1 trial, to be more specific, since you are the since it's co-PI, they actually made very clearly syndrome complexes which would be included in TIA, that any symptom complex would not be a TIA. So they actually wrote down the specific types of lesions or type of clinical complexes, for example, right-sided hemiparesis, bilateral cordyparesis, things like that to be included. So I think that's how they try to differentiate patients from migraines and TIAs.
I don't think they know what they're talking about. I'm serious. I think we have learned so much in this entire field. The neurologists are changing their opinions about what a migraine is. When I went to medical school, I don't know about how, 6,000 years ago, right? We were told that a migraine was due to intense vasospasm of the arterial circulation and then relaxation, and that the pain of the headache was due to the throbbing from the blood flowing through the artery. Well, now the studies show the complete opposite, that it's actually vasodilation first and then vasoconstriction, and it's the spreading wave of depolarization through the brain. So the whole area of migraine and neurology, I think, in this area has been very muddled, and they're learning more. They didn't believe that there was this association between PFO and the migraines, the heart and the brain. But although it's still not proven, there is just so much observational data to suggest this connection between migraines and PFO. We don't know what the cause is. We don't know if it's particulate. We don't know if it's some chemical that's going across. But clearly, that was not discussed in neurology either. They didn't know anything about that either. So I think we're going to learn a lot, and I think eventually we will actually be able to identify what the neurohumoral factors are that go up and trigger the migraine.
Sanjay, do you want to ask a question? Yes.
Is PFO closure reimbursable?
Yes.
Go ahead.
Yeah, it depends. The answer is yes.
Okay, so did you ever think about lobbying to stop reimbursement so that you can finish your randomized clinic?
Yeah, we've actually if you don't mind, I'll take it. We've tried to. The HDE went away, which has helped quite a bit, and there are a number of states that have looked more carefully at the issue of PFO and basically not reimbursing it. So there are. there is more stress put on the reimbursement issue, but if that was to go away, the trials would be done. In fact, the thing that actually helped Closure One and a number of other studies I've been involved in is to either allow Canada or Northern Europe to join the studies, because they're very motivated in cost-contained environments to basically work within these clinical studies. These clinical studies are extremely well reimbursed also for the physicians.
Yeah, I think the PFO closure saga, lack of randomized clinical trial coming to fruition, exemplifies the need for evidence-based reimbursement. It applies to medical therapy versus revascular therapy for chronic stable angina. It applies to the PFO closure device, and it's about time we start paying attention to evidence-based reimbursement.
Well, the biggest sin, the etiology that was really the worst is carotid stenting. That you have carotid stents available prior to CREST, and then you have all these registries on the side. CREST should have been the first study that was done. So it's been really a challenge, and I agree, frankly. But the real problem is then once you get an indication and you have evidence-based medicine, CMS could basically decide that they don't want to reimburse it. So then they become basically the regulators of medical therapy, CMS. So it is two agencies that don't speak well to each other, and I can't speak to the specifics of that, but clearly you obviously understand the nuances there, but it's challenging. And I think the other thing that John said is really critical is that Closure One and Respect are going to have a lot of challenges because the real high-risk patients, the one that I was identifying in my slides, those floppy intratracheal septums, those big spinnakers bouncing back and forth, a lot of those patients never made it to the clinical sites. They were all closed in the periphery because there was just such a strong feeling that that's what should be done. So these studies may be enrolling very, very low-risk patients, and that would be a sin because that's going to really set us back 5 years.
So I think we should end over here. I think you said the last statement where I said that is the problem with this trial is that so many patients got closed off-label that we lost the ones.
A lot of the health. Yeah.
Thank you.
Thank you.